Thank you. So we've definitely had our share of issues with flights because this was supposed to be the last talk of the day, but we didn't think Dr. Hillman was going to make it in time, so we moved him to the last talk. My task is to really talk about what's the next frontier in CLL, and what I really hope to show all of you is what I think is really the unmet medical need, what we really need to do next to help our patients, and what hopefully will be the final thing that we need to do to help our patients. I do have to say, we talked a lot about myeloma this morning. The truth of the matter is I thank my lucky stars every day that I'm a CLL doctor and don't have to, like the rest of my colleagues, really deal with a lot of very, very sick patients. So here are my disclosures. So we've often talked about this is a slide I think many have seen before, and it actually goes hand in hand with the data from MD Anderson showing the improvement in survival by decades. And I apologize for that slide being dropped. And it looks like when you look at the historical data that we're actually having an improvement in our outcome for our CLL patients in that they're living longer. But what really is important is that when you look stage for stage, and these are data from Europe, so they're using Binet stage, but when you look stage for stage from 1970s to 80s to 90s, the improvement in survival you can see from 38 months to 93 months really is completely due to lead time bias. And it's really because of us diagnosing patients earlier and earlier in their CLL stage. So the problem is, of course, is we've really not had any improvement in the outcome for patients. And the 2010, as I mentioned earlier, is a very good cutoff because this is really when we started to have all of our novel agents. And so my hope is that we can actually start seeing a real improvement in our survival for these patients, and hopefully we can expect a normal life expectancy at one point in time in the future. So what do I think is going to help us get to this, and what is really the next frontier? So the next frontier, I think, are these non-chemotherapeutic approaches to CLL. We have our novel agents, which really include B-cell-associated kinase inhibitors and BCL2 inhibitors. And we really have an array of them coming up. So the first were Syk inhibitors, and fosfominatinib was actually first studied in CLL and NHL back in the mid-2000s. So probably 2007 plenary session at ASCO, Jonathan Freeberg gave the sort of the phase 1 results. Now, the fosfominatinib's only being developed currently in rheumatologic disease, but it certainly showed interesting efficacy. We currently have entosplenib, which is a Gilead compound that's currently in phase 2 studies. And then the next target is BTK. And we have Ibrutinib, which we've heard a lot about, acalabrutinib, which I consider to be a second generation, which we've heard a lot about, and tirabrutinib, which is the GS4059, the formerly the Ono compound, is also what I would consider to be a second generation BTK inhibitor. And later we'll talk about the third generation and what's to come. And then we have the PI3 kinase inhibitors, and we have idelalisib, duvelisib, and umbralisib. So duvelisib was approved about 3 weeks ago. I believe umbralisib is going to be likely the next one for approval, probably in about 6 to 12 months. And then we have our BCL2 inhibitors, so we have venetoclax. What's important to keep in mind is we do have an array of other agents looking at other targets besides BCL2. So MCL1, which some data suggests plays a very key role in mediating resistance to venetoclax, is currently we have inhibitors for that in trial that will hopefully be either used after people progress on venetoclax or even in combination with venetoclax to really knock down both of the anti-apoptotic molecules. But when we look at ibrutinib, and I'm going to use ibrutinib here as my demonstrative example, and I'm going to speak to actually BTK inhibitor therapy as what I now consider to be the standard of care for our treatment of our CLL patients. And you've heard other people talk about FCR as being the standard of care. Well, in my office, no one gets FCR, and it's ibrutinib is the standard of care. And if you're treatment naive over the age of 65 and you get ibrutinib as your first-line therapy, you have an amazing outcome with a 92% freedom from progression at 5 years. So these are the Pharmacyclics 1102 data. So this is the first phase 2 study that will have 7.5-year follow-up being presented at ASH this December. So the truth is, these two people who progressed were both 17p deleted patients. So the first one had a Richter's transformation. The second one developed a CLL progression. I'm going to speak more to those in a moment. But if you're not 17p deleted and you get ibrutinib, and you can tolerate the ibrutinib and stay on the ibrutinib, arguably you need nothing else. Unfortunately, the same is not true for the relapse refractory patients, where we see a continuous downward trend in progression. And I think it's important we take a look and try to identify who and what are these patients that aren't being well served by ibrutinib. So basically, who are those that will not have long-term disease control with BTK inhibition? That is what I think is the most important question. Can we identify these patients ahead of time? And it looks like there was an issue. And the answer is yes, but let's sort of go over what we have. So I'd like to point out that there are really two types of BTK failures. All right, the first one are the patients who have CLL, respond, and then progress, but when they progress, they still have CLL. All right, and these mutations, there's interesting data from Jan Berger and Dan Landau, really showing that these mutations probably pre-exist the initiation of ibrutinib therapy. So these aren't mutations developing on ibrutinib, they're mutations that are developing probably just as a measure of genomic instability in the CLL clone that we're then selecting for with ibrutinib therapy. And what I have here are really the two most common are going to be the BTK 481S and the PLC gamma S707Y. And I'll talk more specifically about the BTK mutation, but the PLC gamma 2 mutation is really a bypass track. You get upregulation of PLC gamma, and all of a sudden it's a BTK independent activation of the pathway. But the second type of CLL progression is actually a transformation. So our novel agents don't work on Richter's transformations. And so we have patients who have CLL that responds and then develop a Richter's transformation. So two different types of progressions, CLL versus Richter's. So these are data from OSU, published by Jennifer Woak, looking at causes of BTK discontinuation. And you can see here a rate of BTK discontinuation for other events, that's 20%. And that's going to certainly be most commonly adverse events. Someone had mentioned earlier that the discontinuation rate was 40%, but I'd like to point out that it's 20% for adverse events, 40% for all causes. And the other causes that we see play a role are going to be the Richter's transformations, which really start to occur immediately and plateau at 2 years, and then CLL progressions, which really seem to start late and cross the Richter's curve at about year 2 to 3 and are continuing to increase. And what's going to be important to see is whether or not there's a plateau here, because it may suggest, as I believe, and when you look at the data from Jan Berger, that the mutations that lead to the CLL resistance actually happened before the ibrutinib started, not once the ibrutinib's initiated, and then the clone just grows out. And so what we're looking at during this time is the time for that clone to grow. So arguably, if we're trying to devise means for preventing resistance, it's possible to identify the patients who are going to develop this CLL resistance ahead of time and treat them differently. And I'll talk about some strategies, but one, of course, would be the early initiation of therapy before the mutation occurs, or with combination therapy that would allow you to knock down both, multiple pathways and prevent the development of resistance. So when looking at the data from OSU, they identified different factors that were involved in transformation, namely complex karyotype and MYC abnormalities, and CLL, complex karyotype, deletion 17p, and age over 65 as a protective factor. And I think that's very important because when we look at the phase 2 data that I just showed of the treatment-naive population, remember those were treatment-naive patients over the age of 65. And so that is something that may also factor in. But what I think we're looking at here with the complex karyotype and the 17p deletion is really genomic instability. And it's this instability that allows the mutations to be occurring and accumulating in the marrow, and that will actually allow the resistance to develop. So when we delve in a little bit deeper at the relapse refractory population from the 1102 study, what you see here is that interphase FISH, as it turns out, is a very significant predictor of overall outcome on ibrutinib. And you can see here that the median PFS for 17p deletion and 11q deletion are 26 and 56 months respectively, and the 5-year PFS is 19 and 33%. So clearly these are populations that need something more, albeit these data aren't so absolutely clear-cut, because when you look at cleaner data from a different study, namely the Resonate study, which was a comparison of ibrutinib to ofatumumab in relapse disease, and so we were dealing with patients that were not as heavily treated because this was obviously a later study, we actually don't see an impact of interphase FISH on outcome. But from my belief and from what we've seen, and remember these data are a little bit shorter in follow-up duration, so they may change as they mature. But from my belief, we really do see an impact of interphase FISH on outcome with patients having 17p and 11q deletions faring worse. And so taken all together, if you have a patient over 65 who has no complex karyotype and does not have 17p deletion, their risk of progression of their CLL at 4 years on ibrutinib therapy is only 1.9%. Those patients, we can say, put them on BTK inhibitor therapy and they're done. For those patients who are younger than 65, have a complex karyotype, and have a 17p deletion, their risk of progression at 4 years is 44%. And remember, the 4 years isn't the plateau, so it's going to increase. So clearly, when you're sitting across the desk from a patient and looking at them and wondering, how can I predict what's going to be the future for this patient and what do they need in order to enjoy normal life expectancy, I really believe that these are the prognostic markers that are going to matter most. Remember, there's no BRC3 here, there's no SF3B1. I'll show some data for a few others that I think are very relevant, but here we have really a way to look and identify the patients who are going to need additional therapy. But what about Richter's transformation? So here you saw these data earlier. This is from the Mayo Clinic, where we see the risk of Richter's transformation being about 0.5% per year in all patients and 1% per year in those from the time of first treatment. Now, what I'd like to point out from these data is that the median time to Richter's transformation was 1.8 years. And that's something that I think that we forget. So it's very short. And in 46% of the patients, the Richter's transformation happened prior to them receiving any therapy. And what this all speaks to is probably what's one of the most important take-home messages, that Richter's is really the biology of the CLL and not necessarily something treatment-related. I'm going to contradict myself in a moment, but bear that in mind. So this is really something inherent in the CLL cells, and so it ostensibly is something that we can identify early in diagnosis and perhaps intervene differently for, and that's sort of a very important idea. Of course, there are the two different types of Richters, the clonally related and the clonally unrelated. Of course, the prognosis is very poor for the clonally related, with the median overall survival of only 14.2 months. So what are the baseline risk factors that are associated with Richter's transformation? So complex karyotype, I think, is really one of the more important ones. Unfortunately, it's not commercially available. It's a very difficult assay to do, and it's important that it be done correctly, because I've seen many karyotyping done on CLL cells that were actually done improperly and led to very incorrect dose results, which could really have a significant impact on the patient's prognosis and overall outcome. Interphase FISH risk category, advanced rise stage, beta-2 microglobulin, unmutated immunoglobulin gene, stereotyped B-cell receptors, ZAP70, CD49, and CD38 expression, and purine analog and alkylator agent therapy together. And this is actually, these are interesting data showing that there's no increased risk with patients who got fludarabine as a single agent and no increased risk with the patients who got cyclophosphamide-based therapy, but the patients who had the fludarabine plus cyclophosphamide had a significantly increased risk of developing a Richter's transformation. So it's important, the cyclophosphamide isn't protective. It isn't like having received those were in some way able to protect you from having the Richters, but it certainly is important when you want to look at ways that we have to avoid developing Richter's transformations. So one of the most telling genes that I believe at diagnosis that's going to be helpful is the Notch1 mutation. So this Notch1 mutation actually causes a frame shift and you lose the PES domain, and so the Notch1 becomes basically constitutive. Once it's activated, it stays on. So it actually the cell loses the ability to turn it off. And what happens is the Notch1 activation leads to NF-kappa B activation, and ostensibly that leads to increased survival and transformation. So you can see in the patients who have the Notch1 mutation, the risk at 15 years is about 45%, but you can see the vast majority of this risk is going to be within the first 5 years. So this represents a very significant number of patients. And if we talk about 10% of the patients having Notch1 mutation in general, and importantly, Notch1 is almost always present at diagnosis. So this is actually something that you could know on day one of the patient's presentation. We all of a sudden have identified 5% of the population, of the CLL population overall, who's going to be developing a Richter's transformation. So in essence, this could be half of those patients. When we look at stereotyped B-cell receptors, and the data for 4-39 actually has been a little bit controversial. Dr. Rossi didn't present his data in contrast to the Mayo Clinic data. But what's interesting is these are stereotyped B-cell receptors. They come in IgG and IgM surface-expressing variants. And I believe the IgG surface-expressing 4-39 patients have probably a 100% chance of transforming, and maybe the IgMs have a 0. And those are data that will hopefully be forthcoming. But for now, we know that it's about a 50% risk at 5 years. Now, 4-39 is probably only going to be about 2% of the CLL population, so this might only explain 1%. So now we can get from the 5% to 6% of the patient population overall who are going to develop a Richter's transformation. So my hope is slowly we can identify these patients ahead of time and figure a different means to intervene for them. Now, what's interesting about these two features is that if you pool them together, you get to 100% risk of Richter's transformation at 5 years. So if you're sitting across from a patient who has a 100% chance of developing a Richter's transformation, you can't sit there and say, let's watch and wait. And you can't sit there and say, oh, I think you'll do well on single-agent Ibrutinib, because we know that that's going to be a problem. Granted, we don't have data that Ibrutinib doesn't impact upon this, but we do have the patients from the treatment-naive group who did develop Richter's transformations. So in essence, when is Ibrutinib alone or BTK inhibitor therapy not sufficient? So one is the CLL progression, so the 17p deletion, complex karyotype, age less than 65, and the Richter's transformation cohort progression, which is going to be the 17p complex karyotype MYC abnormality, and it's mostly going to be overexpression, though occasionally translocation, Notch1 mutation, stereotyped B-cell receptors, and combination purine analog and alkylator therapy. So these are the prognostic markers that matter to me, and the question now is what can we do? So for high-risk CLL, that group that has a 1.9% chance of progressing on BTK inhibitor therapy, we're done and we don't need to do anything for them. But for all else, and this is how I describe high-risk CLL, these patients who are going to not do well on long-term Ibrutinib, I think we need to do several things. One is revisit, watch, and wait. Oh, sorry about that. And, it's during the watch and wait that we see these resistant clones developing. And it's sort of enabling those clones to develop that we need to prevent. And initiating therapy early with something that's going to stop proliferation and perhaps stop ongoing mutation really could be something that would be successful. But the key is that we have to have therapy that's not going to be long-term toxic, therapy that we're not going to be concerned having patients on indefinitely, and that this has to be non-genotoxic therapy. So I think we have data now approaching 7.5 years that will suggest that Ibrutinib for those patients who can tolerate it will be sufficient. The next is combination therapy, and this is ibrutinib plus venetoclax currently, but there are many, many others. In this morning's talk, I mentioned them. I just want to once again highlight the Captivate study, which is the PCYC 1142 study, which is looking at treatment-naive patients who need therapy. Patients are going to be all treated with 3 months of ibrutinib as a single agent to debulk them, and then receive ibrutinib plus venetoclax for 12 months, and so that's a 15-month treatment course, 12 months of combination, with a randomization for the MRD cohort, where they're going to be randomized to either getting, based upon whether or not they're MRD negative or MRD positive, to either getting placebo or ibrutinib, and if they're MRD positive, being randomized to getting ibrutinib or ibrutinib venetoclax. All right, and I showed you the data this morning for the first group of patients, and the truth is, with very, very good data so far on achieving MRD negativity, the hope is with therapy discontinuation, we can actually continue to see excellent outcomes. And then I just, in the last 2 minutes, want to talk about the other option, which are third-generation BTK inhibitors. All right, so here we have a curve looking at ibrutinib's impact on inhibiting the normal BTK, and then this is the BTK with the cysteine 41 serine mutation. So ibrutinib does fit into the pocket not as well, and that's why we see this curve shifted. But the most important reason why we see ibrutinib lose its effectiveness is because the ibrutinib is not covalently bound and gets metabolized and cleared, and so the BTK is able to resume its activity. If we had an inhibitor of the BTK that functioned 24 hours and therefore had complete coverage of the enzyme as a reversible, not dependent upon the cysteine at position 41, we could overcome this. And this actually basically shows that, here during the fall off of, or the metabolism of ibrutinib, we get a very quick fall off in its levels. And at this point in time, we would see BTK reactivated if ibrutinib was not covalently bound. So here we have vecibrutinib, or SNS-062, which is a reversible inhibitor of BTK and is actually able to provide 24-hour coverage that will enable at least the resistance that's mediated by the cysteine mutation to be overcome. Now, an important component of all this is to dial out some of the the EGFR inhibition and the TEC kinase inhibition, all the other inhibitions, because 24-hour coverage would lead to a lot of other toxicities, mostly worsening diarrhea, rash, platelet dysfunction. And so an important component of this is not just the 24-hour coverage, but also the improved selectivity. And then another agent, LOXO-305, so SNS-062 is actually in its third cohort of phase 1 study, and LOXO-305 is about to enter its phase 1 study, and very similarly has a very nice affinity for BTK regardless of the presence of the mutation or not. So these are actually what I see as the problems and some potential solutions to these in the future. Thank you.